It's my pleasure to invite Ola Kvist. Ola comes to us from Sweden, and he's a pediatric radiologist.
I have to say that since I got invited, I'm actually now at Columbia University. So I'm moved across to the other side, but I'm actually in Europe quite now. But I would like to say that the topic of the day is how we can use MRI for insights into normal and abnormal growth. I have no disclosures. Of course, we have a very complex area that I find very interesting. We have the epiphyseal cartilage, then it becomes a secondary ossification center, and then the physis, the metaphysis, then we get this zone of provisional calcification that lies between there, as well as a small region called the metaphyseal spongiosa. And then, of course, the secondary physis and the articular cartilage. So what I've been focusing more on has been the growth plate, and especially what happens with the chondrocytes when they go from being in the resting zone, where they're being the stem cells quite small, when they move over to the proliferative zone, when they become sort of like small bricks on top of each other, and then when they move into the hypertrophic zone, they balloons like fried egg and then breaks, and we have calcium that leaks out, which then causes the mineralization, and then it turns over into bone in the primary spongiosa. So I'm not a histologist, but my thing is to, how can I have something like this? Here we have those very nice columns, and then we have MRI that is something like this. And how can we then create the growth plate that, of course, is like this plate between it, and how we can get insights in how it grows. So in an MRI image, we can actually see it fairly well because we have this bright line that is usually the primary spongiosa, this black line that is the zone of provisional calcification, and then a white line that is the physis itself. Of course, depending on what kind of sequence, it sometimes can be slightly more difficult, but as long as you have that water is being enhanced, you can usually see the white line, and that is the primary spongiosa, and then also the physis. But then the most interesting part is that we have these growth plate that we can see. It becomes smaller when we reach puberty, but then somehow it ceases and it disappears. So something is working here, and something that is probably that we can measure. So my main question that was started 6 years ago was, how can we see when the bone is something short and what makes it become longer? And can we assess it easier with the MR? And can we see we actually see it in radiograph, or it might even be too late. So we have this structure, we have the growth that is perpendicular to the growth plate. So it's very important that nothing happens to it regarding like Salter-Harris fractures, infection, or something else, because that can affect it. And it actually comes so we can see it very well. We can even see the symmetrical pattern on a CT that shows the calcification, not the water itself, that then, or the chondrocytes, which then could actually be a pattern with a symmetry that we can measure. So the question then is, how can we see these columns on histology, and what does happen when we look with diffusion tensor imaging? This is a technique that shows water, how it flows in a certain direction. So thus we can see these channels, and that can be an indicator of growth. So for instance, we have a 10-year-old boy, then we have few tracts. They're not so many, they're not so long, they're not so regular, and we do not have so much symmetry. When they go older, coming closer to pre-puberty, we see that there are more, especially we see they're more in the tibia in comparison to the femur. When they turn 13, on the other hand, and it's having the growth spurt, they become quite a few, or quite a lot, and they're being symmetrical, and something happens with them regarding volume, number, and length. And then when we turn 15, when we start to decline in our growth, we can see they become fewer, they're not symmetrical, and eventually they more or less disappears. So what how can we actually correlate it? If we have a 14-year-old male in this case, and then we do the tractography, we can see that we have quite a few of these. We have more tracts in the femur than in the tibia. And when we measured a year later, the femur has grown 9 millimeter, whereas the proximal tibia 6 millimeters. So we could actually see that distal femur and the physical tracts are larger, thicker, and more numerous in relation to the proximal tibia physis. And also we see a difference in the activity. Another way to look at it is we have one individual in the top row, we have a different individual on the bottom row, and we could see that we have more tracts in the upper row, that we have a larger volume as well, and they're being longer. And just to specify, the upper person is 12.9-year-old female. She would grow approximately 12.5 centimeter per year if it would continue throughout the entire year, whereas the bottom row is a 15-year-old female that would grow 1.5 centimeter per year. So now we know fairly well what it looks like in a normal person. But the good thing is then we can start to assess therapies, for instance, growth hormone. So we have now an ongoing study where we have a baseline, we do an exam of an individual, then they start the growth hormone therapy, and we follow them after 4 and 8 months. And then we have ongoing to keep on following them. But then we could see that the tract count and volume increases, but we also could see quite significant increase of height as well. So this is a good thing. We can actually measure how well it works, and even more so if we start having discussion regarding responder, non-responder, because the non-responders are those we're being quite worried about, is that to the left here, we have a 12-year-old male that we have a lot of tracts being symmetrical. They will be approximately 10 centimeter per year according to a rough measurement. But on the right-hand side, we have an 11-year-old female, and they are not being so long, they're not symmetrical, especially in the tibia, they're going all over the place, and that will be about 3.5 centimeters. So this is someone that doesn't have any response to the growth hormone therapy, and more or less just would have the side effects of it. So this is something that we need to develop and look at further and ongoing. Another thing that we also can see is, of course, are the acquired injuries of the growth plate. So here we have the Salter-Harris tube fracture. We can even see in the middle of the distal femur that the growth plate is gone because it's more or less fused. And when we add on the diffusion tensor imaging, we can see that it's quite a big difference between the medial and lateral side. And even more so, when we look at the comparison, we can see that it's a significant difference. So diffusion tensor imaging is probable that we can see these injuries of the growth plate quite earlier, and then hopefully we can have some interventions before it fuses completely. So what I would like to say to you is what I found, and I hope in the future we can find even more, is that we can image the site of endochondral ossification, thus the growth. This we already know, of course. The cartilage itself is organized in columns that elongate, and the newly formed bone reflects the cartilage function. The combination of these and the organized architecture allows the diffusion tensor imaging, DTI, to depict this and also quantify the number of tracts and actual growth itself. And I would like to thank you for taking your time. And if you have questions, please ask. And also if you have any research points, please let me know. Thank you so much.